Now let's study neonatal respiratory distress syndrome. As we know, around 28th week of development of the fetus, there will be production of surfactant from the type 2 pneumocytes. But in premature baby or due to any condition where there is surfactant deficiency, there will be increase in the surface tension. As we know, for alveoli to remain open, there should be enough surfactant to keep them open. But in surfactant deficiency, these alveoli will always tend to close because due to surface tension. There will be alveolar collapse, and this can be seen as ground glass appearance on lung field. As we can see here, this is the premature baby, and here we can see the haziness and ground glass appearance in the lung field. And the risk factor for neonatal respiratory distress syndrome include prematurity, the baby which is born before 28th week, and diabetes during pregnancy and C-section. Prematurity because surfactant develops after 28th week from the type 2 pneumocytes, and if the baby is born before 28th week, there will be no surfactant production, so there will be increased surface tension that leads to alveolar collapse. And for screening of the fetal lung maturity, we can measure the LS ratio, that is lecithin and sphingomyelin ratio in the amniotic fluid. Normally, lecithin to sphingomyelin ratio is more than 2, which is seen in healthy baby, and if LS ratio is less than 1.5, then it is suggestive of NRDS, that is neonatal respiratory distress syndrome. And we can also measure the foam stability index and surfactant albumin ratio. And during diabetes during the pregnancy, because insulin decreases the fetal surfactant production. So during maternal diabetes, there will be increase in the glucose that goes to the baby's circulation, and that reaches the pancreas, and that pancreas senses the glucose, and there will be a release of more insulin from the baby's pancreas. That insulin will inhibit the surfactant production, hence there will be neonatal respiratory distress syndrome in the baby. And C-section delivery, because normally glucocorticoids are necessary, and they increase the production of surfactant from the type 2 pneumocytes, and they also release the surfactant from the type 2 pneumocytes. They also promote the release of surfactant from the type 2 pneumocytes. But during C-section delivery, there will be no stress, so there will be no production of glucocorticoids in the baby. So there will be less production of surfactant from the type 2 pneumocytes. And if oxygen is given to the if oxygen supplementation is given due to premature lung, due to increase in the production of free radicals from the oxygen, that free radical will injure some kind of tissues, like it can injure the retina and cause blindness, and it can also injure the premature lung and also causes the bronchopulmonary dysplasia. And in premature lung, there will be low oxygen tension, so there will be increased risk for patent ductus arteriosus. Normally after birth there will be increase in the oxygen tension, but in these premature babies there will be low oxygen tension that leads to remaining or there will be no closing of the ductus arteriosus, so that leads to patent ductus arteriosus. And the treatment include maternal glucocorticoids before the birth and exogenous surfactant for the baby. And therapeutic oxygen results in retinopathy of prematurity. As I said earlier, there will be production of free radicals from the oxygen supplementation that leads to blindness, and intraventricular hemorrhages can also develop, and bronchopulmonary dysplasia, that is due to free radical injury to the premature lung.